Welcome everyone to the latest installment of EMS Focus, a collaborative federal webinar series. My name is Max Severide, and I'm an Emergency Medical Services or EMS specialist with the National Highway Traffic Safety Administration, or NHTSA, and its Office of EMS. Together with our federal partners, the Office of EMS is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help with a few things: system improvements, measuring the health of EMS systems nationwide, and delivering the data that EMS leaders need to advance their individual systems. Another role of our office is to educate the EMS community in new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. This free webinar series hosted by NHTSA's Office of EMS is a unique opportunity for federal EMS agencies and industry experts to share information with the EMS community. Our EMS Focus conducts webinars several times throughout the year on issues that are important to the EMS community and provides you with timely information on what federal agencies are doing about them. Today's webinar is being recorded and will be archived on our website, ems.gov, for future viewing and listening. There will be time at the end of the webinar for questions, but feel free to type questions or comments using the chat feature throughout the webinar. More information on the EMS webinar series can be found on ems.gov. Like much of medicine, the care provided by EMS clinicians in the past was often based on what we thought would work based on knowledge of physiology and pharmacology at the time, but was not necessarily backed up by extensive research and evidence. While much of that care saved many lives, we know now that certain treatments, unfortunately once believed to be life-saving, may have actually been ineffective or even harmful. The use of evidence-based guidelines is helping to change that. As increased access to data and research creates more evidence, the care delivered in the field continues to improve patient safety and outcomes. Today, we'd like to talk about the critical role of evidence-based guidelines, which we'll use the acronym today, EBGs for short. We'll discuss EBGs' use in EMS and how some EBGs are created. We'll use the recent EBG on pre-hospital administration of naloxone to discuss the extensive process that's undertaken to create guidelines that are based on the best evidence. And we'll also hear about the Pre-Hospital Guidelines Consortium to talk about the future of evidence-based practice in EMS. Evidence-based practice is at the heart of the vision for a people-centered EMS system, described in EMS Agenda 2050. The vision says that in the future, EMS care in every community is based on the best available evidence. That includes clinical care, operations, and all aspects of EMS systems. EBGs are a critical piece of helping us achieve this vision for patients, clinicians, and communities. We all want to do what's best for patients, and EBGs really help ensure we are doing just that. We have a great lineup of speakers today joining us to discuss this important topic. First, you'll hear from Dr. David Nemer. David is a medical officer in the Center for Evidence-Based Practice within the Agency of Healthcare Research and Quality. He's responsible to further the dissemination of patient-centered outcome research evidence on what works in health and healthcare delivery, and to help catalyze practice improvement across healthcare settings. Second, you'll hear from Dr. Ken Williams. Ken is an EMS and emergency physician in Rhode Island. He's medical director for LifePact, Rhode Island's critical care transport service, medical director for the Rhode Island Department of Health Center for EMS, and an immediate past chair of the Medical Directors Council on the National Association of State EMS Officials. He's also a professor of emergency medicine from Brown University. Thirdly, you'll hear from Dr. Martin Gill. Chris is an associate professor of emergency medicine and a chief of the Division of EMS at the University of Pittsburgh Medical Center. He was the principal investigator in the development of the National Pre-Hospital EBG strategy and now serves as the chair of the Pre-Hospital Guidelines Consortium. And then finally, you'll hear from me, your MC for the webinar today. I'd like to turn first to Dr. Nemer to start off with an overview of the systematic review process and findings. David?
Thanks very much, Max. Can everybody hear me okay? Okay, so today I'd like to speak to you for just a few minutes about a recent systematic review that we completed at the Agency of Healthcare Research and Quality, or AHRQ. You can see before you the title, Management of Suspected Opioid Overdose with Naloxone by EMS Personnel. Now, I should acknowledge this report was written by the Pacific Northwest Evidence-Based Practice Center with Dr. Roger Chow as the principal investigator. There's a link on this slide to the full report if you're interested in reviewing that. Next slide is my disclosures. So this work was accomplished under a contract between ARC and the Pacific Northwest EPC, and the findings and conclusions are those of the authors and not represented at the official position of ARC or the Department of Health and Human Services. I should mention that the authors of the report had no financial or non-financial disclosure conflicts of interest to disclose. Next slide. So what I have here is a schematic of the evidence review process. In short, the process evaluates published literature, evaluates the quality of each individual study that meets the criteria for the population, intervention, and outcome of the particular topic, summarizes that overall evidence, evaluates the risk of bias, does either a qualitative or a quantitative summary, synthesis rather, of the evidence, and draws conclusions in response to the key questions. Now, common uses of evidence reports include informing program planning, making policy and coverage decisions, developing or updating clinical guidelines, and setting or prioritizing research agendas. Next slide, please. This is a schematic of the process from evidence synthesis through guideline development or coverage decisions to practice change and finally to improved health outcomes. So federal agencies, medical professional societies, and health systems can therefore make better healthcare policies, better clinical guidelines, and better health decisions, ultimately leading to longer, healthier lives for all of Americans. Next slide, please. So the purpose of this specific systematic review on naloxone administration in the pre-hospital setting was to compare different routes, doses, and dosing strategies of naloxone administration for suspected opioid overdose by emergency medical service personnel in field settings. And secondly, to compare the effects of transport to a healthcare facility versus non-transport following successful reversal of opioid overdose with naloxone. So the review had 4 key questions, and I'll read them briefly. Number 1, what are the comparative benefits and harms of out-of-hospital administration of naloxone by various routes of administration and various doses? Number 2, what are the comparative benefits and harms of titration of naloxone until the patient resumes sufficient spontaneous respiratory effort versus regains consciousness? Number 3, what are the comparative benefits and harms of differences in timing of repeat dosing of naloxone? And finally, what are the benefits and harms of transporting patients to a healthcare facility versus not transporting them? Next slide, please. So this slide is a basic overview, if you will, of the methods of performing a systematic review. We began with a topic refinement where a panel of key informants were assembled to have input into the scope of the review and the key questions. And out of that was drafted a protocol for the systematic review. The protocol specified the literature search strategy, the inclusion and exclusion criteria for the literature, how the data from the literature would be extracted, how the risk of bias would be assessed for each individual study, then how the research applicability of the findings would be made. The next step was the data synthesis. And that included both qualitative and quantitative or meta-analysis, and then how the body of evidence will be rated. In particular, that's our strength of evidence grading, which varies from insufficient to high. And then finally, when we had the draft report, it was posted for both peer and public review. and revisions to the report were made in response to reviewers' comments. Next slide, please. So this is the Prisma diagram of what evidence is available. Don't mean to go through it in detail, but just to say that the Pacific Northwest Evidence-Based Practice Center started with over 1,900 abstracts, but boiled them down to 13 included publications. And those 13 were distributed over just the first and fourth key questions. And therefore, the second and third key questions, there was no literature found relevant to those questions. Next slide, please. So beginning with the results for key question 1 regarding the routes of administration for naloxone. The first conclusion was that higher concentrations of intranasal naloxone may be similarly effective and safe compared with intramuscular naloxone. Now, the literature found 4 randomized clinical trials and 4 cohort studies looking at the comparison of intranasal versus intramuscular. And for this body of literature, the authors rated the findings as a low strength of evidence. Literature was also found for the comparison between intranasal versus intravenous naloxone. Here, 1 randomized clinical trial, RCT, and 2 cohort studies were found. But in this case, the evidence here was graded as insufficient. And then the next conclusion, are there differences in effectiveness between doses and routes of administration? And unfortunately, no studies were found in the literature related to this question, and therefore the conclusion was an insufficient strength of evidence. Next slide, please. Turning to the second key question, does titration of naloxone entail spontaneous respiratory effort versus the subject regaining consciousness have a difference in effectiveness? So the authors said that while field administration of naloxone is generally effective in reversing opioid overdoses, there is not strong evidence concerning this particular question of how to titrate naloxone. They found no studies, and therefore their conclusion was there's an insufficient strength of evidence. Next slide, please. The third key question concerning the timing of repeat doses of naloxone, the authors of the systematic review said that more research is needed here to determine optimal doses of naloxone, appropriate timing of repeat dosing, and whether it is necessary to dose patients to full consciousness. And again, unfortunately, no studies were found addressing this question, and the conclusion was insufficient strength of evidence. Next slide, please. Finally, the last key question concerning transport versus not transport, the authors concluded that more research is needed to determine whether transporting patients to a hospital after successful reversal of overdose is necessary. The authors did find 6 uncontrolled studies in individuals not transported, and amongst them, they found a very low death rate. But again, these are uncontrolled studies. And so the authors concluded that for this key question, there was insufficient strength of evidence. Next slide, please. So in conclusion, the authors states that there is additional research that additional research is urgently needed to optimize administration of naloxone by EMS personnel. They suggested that future research could leverage existing EMS registries with naloxone administration data, which are available from a number of local and state agencies. And finally, that research is needed on the comparative effectiveness of the FDA-approved naloxone auto-injectors and of highly concentrated intranasal naloxone formulations, as well as for different doses and different dosing strategies. And that concludes my presentation. Thank you very much.
Great, thank you, David. That's a real great help to understand how to evaluate existing research out there. And now we'd like to turn the webinar over to Dr. Ken Williams to talk about the development of the naloxone EBG. Ken?
Thank you, Max and Dr. Niebauer, for your introduction. It was my honor to lead the Naloxone Evidence-Based Guideline project that picked up from the work that Dr. Niebauer was talking about. I want to thank everyone who is viewing the webinar and everyone who helped organize things. I have a couple of disclosures. I did share this an evidence-based guideline project and was shortly after the project was over, retained by Adapt Pharma, the makers of Narcan nasal spray, to offer some opinions in patent litigation involving their product. My comments are, of course, my own and don't represent NHTSA or any other entity. Some of the slides that you'll see in my presentation are available in the evidence-based guideline training module, which is freely available online, and there are links to that on the screen. So let's talk briefly about naloxone. As probably most of you know, but we're just going to go over the basics so that we have this covered for everyone there. It is an antidote to the effects of opioids, and it works quickly, but not immediately. So it works in 2 to 3 minutes, maybe a little bit faster if it's given intravenously. But 2 to 3 minutes is a reasonably long amount of time if you're in the middle of an emergency, particularly if the patient is in significant distress. Naloxone also is fairly temporary. Its reversal lasts somewhere between 30 and 90 minutes. And therefore, patients who have taken long-acting opioids need to be watched very carefully because they can relapse into an overdose state. There are some potential side effects from naloxone when given to people who are opioid dependent or opioid tolerant. For the non-opioid using population, there are almost no side effects known, but withdrawal and other side effects can occur when naloxone is given to people who are dependent on opioids. It's approved for use in both pediatric and adult patients, and there are multiple routes and doses, which is part of the reason for this project. The next slide should show you a little graphic of how naloxone works. If you think of the little green things that look a little bit like ice cream cones with a pink opioid ball in them, that's the receptor and the opioid on it. The naloxone molecule has a stronger affinity for the receptor than all existing opioids that we know of. And so it kicks the opioid off, but again, it takes a couple of minutes to work. If you give it intravenously, you can begin to see effects in a minute or so, sometimes a little bit less, depending on how much you give and how much opioid the patient has taken. But intranasally, intramuscularly, subcutaneously, and by other routes, it can take 2 to 3 minutes to begin to have effect, and actually doesn't have peak effect for quite a ways after that. So just like opioids, naloxone comes in multiple forms, and there are 4 common ways that it's given in our EMS system: a nasal spray of various concentrations and doses, then by auto-injector into muscular tissue, or by a standard IV syringe route. And there are lots and lots of opioid rescue kits and opioid rescue efforts for community distribution and other uses of the naloxone. So moving on to when you give naloxone, you should only give it when it is indicated. So the indications are a patient who is exhibiting the appropriate findings for a patient who has an overdose situation. And that means depressed mental status, unconscious or semi-conscious, and abnormal breathing in that the breathing is slow, gasping, or absent. You don't give naloxone if the patient is breathing normally or if they're awake. Otherwise, it's not indicated. Your patient may have opioids on board, but they are likely to have some other problem, and naloxone may make things worse and almost certainly is not going to fix the problem. So let's go back to the beginning in a sense here and ask, why are we doing this project? And the next slide makes the point that across the United States, as the opioid crisis became a significant issue, various EMS systems and various jurisdictions had wide variation in the scope of practice about response to opioid overdose and the use of naloxone and its different routes based on the level of training, based on the jurisdiction. There were variations in route, dose, both the initial dose and titration of that dose and repeat dosing, and the decision about transporting patients to the hospital or not, and what the criteria were. And faced with this wide variation, a number of federal agencies and other partners, as shown in the next slide, with funding from NHTSA and HRSA, decided that it would be a good idea to look at the evidence and come up with an evidence-based guideline. So 3 large emergency medicine organizations, the National Association of State EMS Officials, the American College of Emergency Physicians and their EMS committee, and the National Association of EMS Physicians all collaborated on this project. We're certainly thankful to all of them for their support. What happened with this project is shown very quickly on the next slide. There was one expert panel meeting of the group in person. The expert panel was assembled through suggestions and voting by various organizations and sending representatives. And then the rest of the effort was really done by internet and telephone. We looked at the evidence. We, as was alluded to earlier, we graded the evidence actually using a methodology called GRADE, and then produced our guidelines and other deliverables. The technical expert panel, as shown on the next slide, has a lot of broad-based members, including emergency physicians, EMS providers, administrators, educators, but people outside of the EMS world as well, including patient advocates and people who work in the pharmacology and psychology of addiction and harm reduction. So we really had a very broad-based group. The questions, as shown in the next slide, as were mentioned earlier, had to do with the route of administration, the dose, titration of that initial dose, timing of repeat dosing, and then the transport decision. These are called PICO or PICO questions in this type of research. What is the population of interest? What's the intervention you're talking about? What are the things you're comparing A and B? And then what is the outcome that you're measuring? And as was mentioned earlier, some of these questions, we had good literature that we could use to guide our recommendations. And in other cases, we did not have relevant literature. So we used available QA literature, we used QA data from some large systems, and the expertise of our 25-member panel to try to guide things. As an example, in the next slide, you can see one of the grade tables, and this was for a sub-question in question 1 about route, and this is the comparison of intranasal versus intramuscular. And I don't mean for you to be able to read this, but if you look at the paper, these are all laid out for you nicely. But the idea here is that we looked at various things to do with those 4 elements of the PICO questions and graded the evidence, whether it was good quality or not, to come up with our recommendations. The result of this 18 months worth of effort summarized in the next slide, that a paper was published in the journal Prehospital Emergency Care, which summarized all of this work, how the project was put together, the various questions that we answered, the grade tables, and then the other deliverables from the project. This is available on the internet for free. You don't have to have a subscription to the journal. You can just click on it and download the whole paper in PDF for free. Quickly, in the next slide, here are the answers to those questions that we came up with. We found that intranasal was about the same as intravenous as a preferred route, obviously depending on how hard or easy it is to get an IV in a patient or a patient who might already have an IV, and that we preferred both of those to intramuscular for several reasons. Dosing really varied depending on the patient circumstances, but we recommended starting with somewhere between 0.4 and 4 milligrams, again, depending on how you were giving it. Titration was a goal to restore adequate respiratory function and not bring the patient back to full consciousness where there's a significant risk of withdrawal and all of the untoward effects with withdrawal. Repeat dosing, we felt you should be waiting at least 2 to 3 minutes after effect to be sure that you've gotten the full effect that you're looking for before giving an additional dose and again risking withdrawal. And then we recommended that people be transported if possible, or if there is a mechanism to provide them with treatment for recovery at the scene of the incident, whether that's in person or via literature, that some treatment be offered. But it's not enough to just reverse the overdose. You really want to get the patient into permanent treatment to help with their opioid problem. The sample protocol was submitted to the National EMS Model Guidelines Project, as shown on the next slide. This is one of 4 pages of the sample protocol, and that hopefully will be approved and in the National Model Guidelines Project soon. The next slide shows another deliverable. There's a training module with slides that's narrated and again is downloadable and available for free. You can watch it on Vimeo. I think it's 37 minutes or so in length, so it's fairly short and goes over the findings of the project. So to wrap up, the important points are that there are several steps that make a difference for EMS use of naloxone. If you're already part of the EMS system, obviously it doesn't need to be activated, but you want to assess the scene, including safety, start whatever first aid the patient needs, whether that's CPR or bag valve mask ventilation, and give the naloxone by your local recommendation in terms of dose and route, but hopefully will follow our guidelines, and then monitor the patient. The order of these things doesn't matter as much as doing all of the things that are needed for your patient. We want to avoid people getting naloxone and not getting first aid, or getting first aid and not getting naloxone, if naloxone would be helpful. So in the recommendations, we're just saying that these are the essential items, but the exact order isn't really as important as getting all of the things done. And so finally, the lesson I think from this project is that it took 18 months, an effort by the 25 or so people on the panel with a lot of external support, but it answered a number of very important questions and gave us guidance from the best evidence that's available about how we should be using this drug to help combat the opioid crisis. Thank you very much for your time, and I'll turn it over to Max to introduce the next speaker.
Great, thank you, Ken. That really helps us explain, after the description of the hunt for recent research, really what goes into assessing that research, writing the EBG for use now by practitioners. Stay tuned, and we'll actually share pretty soon the links to the ARC report and the naloxone EBG. But first, we'd like to turn next to Dr. Martin Gill to tell us more about the recent and ongoing EBG projects. Chris?
Thank you, Max, and appreciate Dr. Nemer, Dr. Williams sharing a phenomenal amount of effort that went into creating not just a systematic review of the literature from a dedicated group, but also an excellent example of most recent evidence-based guideline that could provide us a good example of some of the tremendous effort being done in this area. What I have been asked to do is to take a step back and give us a perspective on what some of the efforts have been over the past 20 years or so related to the pre-hospital evidence-based guidelines. And I'm going to try to give us a glimpse of what the future may hold for us in this space and the way that different organizations are aiming to work together to try to improve the evidence base behind our pre-hospital care, both on the clinical and operational aspects of EMS. As I do so, I will mention some of the phenomenal efforts that NHTSA and several other organizations have done. I'll be speaking as an informed individual and not speaking on behalf of any particular organization. I will also mention the Prehospital Guidelines Consortium that is aiming to bring together some of the efforts and some of the organizations that are doing some of this incredible work. Next, I want to discuss some brief disclosures on the next slide. I'm currently funded for several research projects that are unrelated to this effort from the Department of Defense, NHLBI, and Pittsburgh Emergency Medicine Foundation. I would mention that I was previously the principal investigator for the National Pre-Hospital Evidence-Based Guidelines strategy that I will be discussing, and was also one of the co-investigators in the fatigue and EMS guideline. Next slide. So going back 2 decades, I think the decade between 1998 and 2007 was a very important part of multiple efforts being done to try to promote more science and evidence behind EMS medicine, and specifically the MSOP efforts try to emphasize the fact that we need to evaluate outcomes in the care that is being delivered in the field. There was the National EMS Research Agenda and several other research-related documents like the National EMS Research Strategic Plan and individual efforts related to pediatric EMS care and acute injury care that were seminal documents to try to focus the efforts being done to improve the science and get more research basis behind the care that was being delivered in the field. Next slide. A lot of this effort culminated in the Institutes of Medicine's report, Emergency Medicine at the Crossroads, which if you read any of these publications in the past year, I'd probably suggest is the most frequently cited publication that raised a loud voice to say that we needed more evidence base behind the care that was being delivered. An interesting quote from that publication was, and I quote, "The pre-hospital emergency care system provides a stark example of how standards of care and clinical protocols can take root despite an almost total lack of evidence to support their use," end quote. That really is very strong language to suggest that we need to increase our efforts for there to be a science base behind the care that we deliver. And certainly going back many decades before, we had been traditionally implementing things that had worked in the hospital setting or other environments to the field. And it's really in the past couple of decades that there has been a huge ramp up in the amount of scientific evidence that we have for the things that we do. Moving forward from those strong words, the National EMS Council and the Federal Interagency Committee on EMS provided information and feedback to federal agencies and other stakeholders to say that we need to have increased efforts to create evidence-based guidelines for EMS care and to make efforts to disseminate those guidelines. Leading from some of those recommendations, NHTSA had funded several individual, NHTSA and actually other federal partners, including the EMSC program from HRSA, among others, funded several individual evidence-based guidelines. And with much similar effort to what Dr. Williams just described, 18 months to a year of work for an individual guideline to be developed, we end up with guidelines for pre-hospital seizure care, air medical transport, pre-hospital analgesia, and external hemorrhage control. Part of that effort was also trying to create a comprehensive list of clinical guidelines that may include those that have been developed through a systematic review of the literature and that we would term a full evidence-based guideline, but also expert-developed content that became the National Model EMS Clinical Guidelines that was created and maintained by NASEMSO and is now actually in its second version. And during this time, you have other efforts, including the development of the National Prehospital Evidence-Based Guidelines Strategy that I will mention in a minute, and creation of other organizations. Next slide. The most recent evidence-based guideline projects that we've seen in the last couple of years that was supported by these groups was the Fatigue and EMS Guidelines with Dr. Patterson in our group, as well as the Naloxone EBG that we just heard about. Next slide. So as we were seeing 2 decades of work with a number of individual guidelines being developed, a number of projects being performed to evaluate the ability to implement guidelines and some of the many challenges that are encountered in trying to do so, as well as substantial effort being done to develop performance measures through the EMS Compass project and other efforts being done in this arena, the National Highway Traffic Safety Administration formed a cooperative agreement with funding from NHTSA and the EMSC program with the National Association of EMS Physicians to create the National Prehospital Evidence-Based Guidelines Strategy. And the aim of this was to create a sustainable process that would promote the development, implementation, and evaluation of Prehospital Evidence-Based Guidelines. And through a 2-year effort from 2013 to 2015, a group of 58 stakeholder organizations got together and developed a series of 7 action items that would help to promote each of these efforts in a sustainable process. The first item of that strategy was to create a consortium of national organizations and federal agencies that can continue to collaborate and promote much of this work that was being done. Other efforts covered in that strategy were to promote research, development of new guidelines, education, facilitate implementation of those guidelines, help to establish standardized evaluation methods, and then promote additional funding for more of these efforts to take place. Next slide. As that first item of the National Prehospital EMS Guidelines strategy, the Prehospital Guidelines Consortium was formed and had its first official meeting in 2016. Now, over the past 3 or 4 years now, this has been a consortium that has aimed to essentially be that sustainable process to promote development, implementation, and evaluation of evidence-based guidelines. Next slide. The consortium is currently formed by representatives of 35 member organizations. 11 of those member organizations have representatives on an executive committee and that help to provide some funding and support for the work of the consortium. And we have liaisons with 7 federal agencies and other research organizations. Next slide. Some of the completed projects that the consortium has done over the past few years is to the development of an online repository of existing prehospital evidence-based guidelines, where you can go and click through and see them organized by different disease groups and treatment groups, as well as some area for operational guidelines. You can access that at prehospitalguidelines.org. Our education committee created an educational module that can be used by any EMS educator on evidence-based medicine and evidence-based guidelines. If you're not aware, the National Registry has recently, in the last couple of years, had added to its requirements for recertification specific content related to evidence-based medicine and EBGs. Certainly, from my viewpoint, quite a welcomed inclusion in that continuing education requirement, and that is for both BLS and ALS providers. We have developed an educational module that covers that content and is also available freely on that website. One of the efforts that has been described as challenging in the EBG world has been the implementation of individual guidelines. And Dr. Fish and other members of our research committee had performed a systematic review of the literature on implementing EMS guidelines, and that is now available in pre-hospital emergency care. And additional educational articles for EMS personnel have been written in NAMT News and EMS World that are now available also for EMS personnel. Next slide. Ongoing projects from the consortium include systematic review of all existing EMS evidence-based guidelines, which we hope will identify where some of the gaps currently exist and help to further support as a resource for individuals that want to access all of that literature. We're updating the NASEMSO statewide EBG implementation toolkit with a more national or local perspective, and including an educational module for folks to implement guidelines at their local or larger setting. Informed by the systematic review of existing EBGs, the research and development committees of the consortium are currently working on a gap analysis to figure out where new or revised guidelines should be created, essentially to inform the community on where the next steps should be in funding or do an additional effort for that process. This is being performed through a Delphi process with over 20 individual stakeholders representing many of the organizations that we've talked about. We're piloting dissemination of new guidelines through our member organizations, and we're collaborating with the National EMS Quality Alliance that has been carrying on the work of EMS Compass to create performance measures moving forward, which we aim to tie to existing guidelines. Of greatest importance is the consortium's effort to continue to bring together its member organizations and to communicate about all of the efforts that we're all working on to help where it can. And in doing so, we'll be having the 5th annual meeting of the consortium in consort with an AMSP annual meeting in San Diego in January. Next slide. I'll take it back over to Max to talk about where to find out additional information for each of these efforts. I know that Dr. Nemer has provided information about the ARC Effective Healthcare Program with some links attached there. For pre-hospital evidence-based guideline resources, you can go directly to prehospitalguidelines.org, where you can access existing guidelines and a variety of other resources. We have the Naloxone, EBG, and other related resources linked there on the NSMSO website. And certainly I can speak for myself and the other speakers in saying that I'm sure we'd all be welcome to receive questions on these efforts. And I can speak for the Prehospital Guidelines Consortium, and that if individuals want to be involved in some of the efforts moving forward, one step would be just to get in touch with me or otherwise access that website. I'll turn it back over to Max.
Awesome. Thank you so much, Drs. Martin Gill, Williams, and Nemer. We appreciate all that context together to bring it all home for everybody on the webinar. We do have some questions, so we'll now use the remaining time to answer those questions that have been posted in the chat window from the audience. Please remember to submit more questions as you get them, but we'll continue for the next 15 minutes of the webinar. And to start, maybe this would be one for Dr. Martin Gill. How do we ensure that the EBGs are kept as up to date as possible if new relevant studies are published? It certainly seems that by the time some of these EBGs are implemented by the state and locals, it's already time to upgrade them.
Yeah, that's a great question. And it really comes to mind that it takes 18 months to 2 years to create one of these robust evidence-based guidelines. In other literature has described that it can take another 2 years to fully implement that in an area. I think what we're trying to work on moving forward here is to first have a good accounting of what evidence-based guidelines currently exist, improve the way that we disseminate those guidelines, and facilitate implementation at the local, state, or even national levels, so that we try to bring those guidelines to the actual providers and individual medical directors more quickly, as well as to try to implement them in a more streamlined fashion. I think that if we work on those efforts and we try to decrease the amount of time that it takes to actually use new guidelines, we'll have a greater period of time where they're actually in use before they need to be updated. But part of the effort that the Guidelines Consortium is actually doing is to identify where we have gaps of no guidelines being performed, and then try to maintain a repository that identifies where individual stakeholders could work on updating the guidelines that do exist.
Great. This question next, I think, might be best for Dr. Williams, and it's a two-part question. Is there a role for the administration of naloxone to patients found in cardiac arrest? And then, additionally, is it useful to emphasize during training that naloxone should or should not be routinely administered during cardiac arrest?
There is conflicting guidance on this, and it was not one of the core questions for our naloxone evidence-based guideline project. But the advice that seemed to come out of the panel as we were discussing it in our meetings was that in the right circumstances, that there's probably a role for a single dose, particularly in, shall we say, either the lay or first responder cardiac arrest situation. In other words, in patients where you don't have advanced airway and advanced monitoring easily available. Just in the circumstances where overdose is possible or likely, and your ability to really detect the difference between cardiac arrest and near cardiac arrest is difficult. But certainly beyond one dose, there's probably not an indication for naloxone in the cardiac arrest situation.
Another question, are there performance measures that agencies and states can use to evaluate whether they are providing EBGs or evidence-based care when treating overdose patients and using naloxone?
Yes, the performance measures were another deliverable of our project, and they are also available. They are, as Dr. Martin Gill mentioned, going to be integrated into performance measure projects for EMS in general.
To follow up with another question, this one for Dr. Nemer, is it common to have so little evidence when AHRQ and its partners perform a systematic review? Can you talk a little bit about the evidence or lack thereof?
I don't think it's common to have 2 out of 4 key questions with insufficient evidence, no. We go through a fairly rigorous process to decide if a topic is viable. But in this case, we were fitting into an effort from NHTSA and their civilian partners. And so the key questions were predetermined, if you will. And it was important for the sponsoring agencies and the professional society partners to really identify research gaps. So, and that's not uncommon. I mean, it does happen rarely. Federal agencies that are research funding agencies will do the same thing. They'll actually insert key questions where they know that the literature might be insufficient, but they really would like the Evidence-Based Practice Center in the systematic review to give some guidance on, the type of studies and study questions, study designs that would really answer the questions. And so I think the answer to your question is it doesn't occur frequently, but it does occur. And there's particular reasons in this case why those questions were included, even though we knew going in that there was not an abundance of literature to address them.
Great. And Dr. Martin Gill, I was curious if there was any additional information that you might like to mention now that we have just a few more minutes as we're waiting for some questions. Maybe take a minute or two of something you'd like to just add a little bit more information to, and we'll look for some additional questions afterwards.
Yeah, thank you, Max. I think, some folks have previously asked about the process to creating evidence-based guidelines and how are we going to move to a future when we have more evidence-based guidelines, for many more topics? NHTSA and others have done a tremendous effort to help to create these individual projects. But when you get down to it, it really just takes a whole lot of effort to make even one of these guidelines a reality. And it's difficult to imagine where we can get to a fully robust set of guidelines. There are things that are being done to try to streamline that process. Certainly, having the funding to support those projects is important, and some of that funding certainly has existed for the efforts to date. But having a streamlined approach to how a guideline may be created, I think, is very important. Dr. Nemer presented on how a specific organization can perform the systematic review of the literature, and as we move to having specialized groups perform those systematic reviews, it becomes more facile to do it for a variety of topics. The next step then is the creation of the guideline, where in prior times, it had spent a lot of time even creating a stakeholder panel to provide input to the guideline and to evaluate the systematic review and then come out with recommendations that are well balanced and representative of a good stakeholder group. In guidelines past, that stakeholder group had to be created guideline by guideline and represented even 6 months of the full effort being done for an individual guideline. Groups like the Prehospital Guidelines Consortium and other efforts aim to streamline some of that work so that we have an existing panel of stakeholders that can be pulled to represent important organizations working in this effort and try to again, streamline the effort to creating some of those new guidelines. I think as we become more experienced in doing so as a community, we'll be able to have more guidelines in less period of time and then move towards that desired outcome of having a robust set.
Thank you. Another question, and maybe I can pose this one to Dr. Nemer. What risks would a medical control physician be exposed to for ordering care which is not evidence-based and or against established standards?
Well, I'm not sure if I'm the best person to answer that question as a non-emergency medicine physician and not an EMS director. But certainly the percent of medicine that is informed by, a systematic review and a evidence-based guideline is a minority. So, I mean, the bottom line is clinicians every day, majority of their clinical decisions are the result of the, subject matter expert opinion, their past experience, their training, that kind of thing. So I think in general, the standard is what would a reasonable physician, trained in this particular specialty do in this circumstance. I think that's the default by which clinicians are, by which clinicians are judged. But hopefully as evidence-based medicine advances, the percentage of clinical decisions that are made by expert opinion and prior experience will be reduced.
Dr. Martin Gill, would you have any additional comment on that in terms of the medical control physician's exposure?
Yeah, I think, that brings up a great point in terms of, should we be worried that as we create guidelines or standards of care, that is going to put us at risk if we don't follow them? I would actually turn the question around, if I could, to say that, we're all at risk for the care that we deliver, that we instruct others to deliver, that we work with our EMS partners to deliver. And it may be that having guidelines that can help us in developing local protocols, in evaluating our performance, and in providing education to our providers, that the net effect is actually to decrease our risk in the care that we're delivering to patients. So I would hope that the availability of such guidelines can inform the care that we deliver and may overall make us safer and at lower risk of liability.
We have a number of people asking about what to do for patients who receive naloxone but refuse transport to the hospital. Any of the three of you would like to chime in on an answer for that?
This is Ken Williams. I'm happy to take a shot at that. That is a very common situation in some systems that we heard about during our project. It's over 50%. And one of the questions that comes up is the dosing and titration and route of the naloxone that's given that is returning patients to a state where they are able to refuse transport and have capacity and competence to do so, as opposed to just restoring adequate airway protection and respiration and allowing them to be transported in that sort of sedated state safely to a hospital for treatment. Obviously, EMS doesn't have total control over this because a lot of naloxone is being given by friends and family members with good intent. So that's thing number one, is education about how we're giving it, which is part of the reason for this guideline, to try to avoid withdrawal, which is a lot of the motivation for people not wanting to be transported because they're uncomfortable and sick and they want to do something to alleviate those symptoms. And then the second part, which I think has been alluded to by a number of people, which just is worth emphasizing, both for performance improvement and for quality assurance type measures, as well as for pure research. Lots of good questions have come out of these projects and are obviously coming from the people that are listening to the presentation that beg further work and research. And so taking a look at what data points are gathered, what data points are common to a lot of the studies, and using those to guide your QA work and hopefully future research projects to answer some of these questions, like what happens to the people who aren't transported, or what happens to patients who get naloxone via a particular device or at a particular dose, where we didn't have a lot of good evidence to guide us. That's in addition to focusing on keeping our evidence-based guidelines up to date. We need people to focus on doing the work to generate the literature that helps inform those guidelines.
Great. I think we're coming to the close of our hour, so I want to thank Drs. Nemer, Williams, and Martin Gill for a great webinar. Thanks to all of you for joining us and for all of your strong EMS support for the community. As a reminder, we'll post the recording of this webinar to our YouTube channel, as well as ems.gov. And please join us for future editions of EMS Focus. If you haven't already, make sure to visit ems.gov, where you can sign up to receive updates about future webinars, as well as other NHTSA Office VM activities. And on behalf of James Owen, the Acting Administrator for the National Highway Traffic Safety Administration, covering our Office of EMS, thanks to everyone and enjoy the rest of your day.